In this ESMO 2024, we also have heard interesting data in kidney cancer. And I think, although the trials that have been presented may not be as impressive as the data that we've seen in other GU cancers this year, I think it's still relevant and is something that is also transferable to our clinical practice tomorrow. Let me start by a study that has tried to answer a question that we confront in our clinic in a daily basis. And the question is sequencing. How do we sequence treatments in metastatic kidney cancer? If we have treated in first line a patient with a checkpoint inhibitor regime, can we re-challenge again this patient with a combination that involves a checkpoint inhibitor? It's true that we had a background, and already in ASCO 2023, I believe, it was presented the results of CONTACT study. So the CONTACT study already presented by Tony Chueri, it showed us that sequencing cabozantinib atezolizumab, so sequencing atezolizumab after a combination that had included a checkpoint inhibitor, did not improve progression-free survival or overall survival. At that point, a number of questions arise. The first one was, okay, why this didn't work? Is it the drug? Maybe atezolizumab is not the right drug. Maybe it's the population, because in that study, it was mandated that the previous regime had to be a regime with a checkpoint inhibitor immediately. Or is it just that the principle from a biological perspective doesn't work? We didn't know. But in this year, ESMO, in ESMO 2024, we've heard the TiNivo-2 study. So TiNivo-2 study tries to answer again this question, but there are subtle differences. Some of the differences are we're using different compounds, and some of the differences we're trying to test it in a slightly different population. The whole principle of TiNivo-2 was patients who had previously received a checkpoint inhibitor in first line were retreated with either Tivo single agent or Tivo plus Nivolumab. So again, we were trying to answer that question of sequencing. And it wasn't only patients who had received one line, could be even further lines of treatment. Unfortunately, the outcomes have not been as we would have expected or as we would have wished. The outcomes have been a negative study. There is no difference in PFS or OS, and actually PFS was the primary endpoint. And when we've done a sub-analysis of that PFS based on whether it was a matter of what was the immediate treatment that patients had received, comparing checkpoint inhibitor versus a TKI, or second versus third line, the outcomes are exactly the same, still negative. So I think this study, even being negative, has an important message. We should go back home and stop sequencing checkpoint inhibitors in kidney cancer, because there is no benefit, there is no clinical benefit, and there is the potential of additive toxicity. So being a negative study, I think, is an interesting message. That's the one study that I think is relevant. There is another study that has been presented that I think is also relevant for our daily clinical practice, and is this study called SUNNIFORECAST or SUNNIFORECAST, depends on how you pronounce it. And let me center the problem. The SUNNIFORECAST is a study testing Nivo plus Ipi in non-clear cell RCC. Non-clear cell RCC is in a scenario where we don't have good treatments. We have never had a valid treatment option with very solid data to support it. So what they did in this academic study was including non-clear cell cancer patients, all histologies, although most of the patients were either papillary or chromophobe, and these patients were randomized to receive either Nivo-Ipi or treatment of choice by the physician. That treatment of choice by the physician in more than 85% of the cases is being a tyrosine kinase inhibitor. So in the end, was comparing Ipi-Nivo versus a tyrosine kinase inhibitor. And guess what? It's been positive in favor of Ipi-Nivo. The percentage of patients that were alive in 1 year was superior and statistically significant for Ipi-Nivo versus the tyrosine kinase inhibitor of choice. I think this is relevant. The study, of course, is not perfect. There are some methodological issues that may need to be reviewed, but I think it's the first randomized phase 3 study in the non-clear cell context that actually shows a signal for checkpoint inhibitors. So important message, I think, is another option to keep in mind when we confront a patient with a non-clear cell histology in our clinic. Lastly, but not less important, a couple of studies that have to do with either new agents or new strategies. Let me mention briefly the LightSpark 005. There was a presentation leading to final outcomes of this study that, as you know, compares Belzutifan versus everolimus in metastatic patients previously treated. Unfortunately, no impact in overall survival. So Belzutifan did not demonstrate an impact in overall survival in this very complicated population, heavily pretreated. The discussion is whether this compound should be moved to earlier stages of the disease in order to really make a difference and have an impact. And lastly, I'd like to mention a study that I found interesting about microbiota. So we heard some data from an Italian study that tested the hypothesis of fecal transplantation in order to improve the response to checkpoint inhibitors. And the outcomes are quite promising, still preliminary, but I think is an area that deserves attention and probably is a new avenue to follow in the future.